we have so much debate on how to approach patients, but we still have so many therapies, fortunately, and those therapies have been born out of our better understanding of disease biology. So we know there's a critical role of the multiple myeloma microenvironment in the bone marrow. We often do not find multiple myeloma in lymph nodes or other places unless a patient has a plasmacytoma, because multiple myeloma likes to home back to the bone marrow where it can grow, and there's a permissive bone marrow microenvironment that supports its growth. So almost all of the agents that have been FDA approved to treat multiple myeloma have been shown not just to target multiple myeloma plasma cells, but also disrupt their survival by support from the bone marrow microenvironment. So the greatest challenge really in multiple myeloma now is how do we cure these patients? We're using multimodal approaches and even monoclonal antibodies up front, like our lymphoma colleagues do, yet we still are not curing the majority of patients. And there are various explanations for why this could be. One of the prevailing explanations is that there's a myeloma stem cell that we're just not targeting. We know that when patients are first diagnosed, they have a predominant clone, but they also have multiple other slightly different clones of the plasma cells that may be resistant to treatment and may persist at low levels until the patient relapses and those clones begin to grow, and those clones may be resistant to subsequent therapies. So I think we need to learn more about what drives clonal resistance, how to use predictive biomarkers that will predict which therapy is best suited for which individual patient. And there are some studies using genomics to guide the choice of therapy, but I think we really need predictive markers, and we need to find regimens that are specific and individualized for specific patients that are going to derive the most benefit in that patient and allow for the longest duration of remission.